All right, let's talk about one of the most clutch skills you can have in the ER or the ICU, using lung ultrasound to spot a pneumothorax, and fast. We're going to walk through a really clear framework, starting with the absolute basics and building up to that one sign that seals the deal. This is stuff you can use on your very next shift.
So here's the big question, right? When you're at the bedside, patient's crashing, can you really spot a pneumo in just a few seconds? And the answer, thanks to lung ultrasound, is a resounding yes. It's a game changer. And believe it or not, it all kicks off with looking for one single beautiful sign.
And that sign? It's called pleural sliding. Honestly, this is the bedrock of using ultrasound for pneumothorax. It's your first move, your starting point. And whether you see it or not, well, that's what sends you down one of two completely different diagnostic roads. So let's break down what you're actually seeing here. That shimmering, kind of glittery line you see on the screen, that's the visceral pleura, which is stuck to the lung, just gliding back and forth against the parietal pleura on the chest wall. It's beautiful, really. It's a sign that everything's okay. When you see that slide, you can basically say with confidence, no pneumothorax here, at least not right under your probe. Okay, but what happens when you put the probe down and that beautiful shimmer just isn't there? The line is just still, static. That's it. That's your first big red flag that something's not right.
Now this is super important. Just because sliding is absent, it does not automatically mean you're looking at a pneumothorax. Not by a long shot. It's a huge clue for sure, but it's not the diagnosis itself. It just means you need to keep digging because there are a few other things that can look exactly the same.
And here's your differential. I mean, of course, pneumothorax is at the top of your mind. Air has gotten in between those two pleural layers, but you've got to think broader. What about a patient who's had a pleurodesis? Those layers are scarred together on purpose. Or maybe they have gnarly adhesions from an old pneumonia. Heck, it could even be as simple as apnea. If the patient isn't breathing, the lung isn't moving, so no slide. You have to run through all these possibilities.
This is a great little cheat sheet comparing a normal lung to a pneumothorax. So look at that pneumothorax column. Yes, sliding is absent, we've covered that. But look what else is gone. B-lines, those vertical comet tail artifacts. You won't see them because the air in the pleural space just blocks them. Same goes for the lung pulse. That subtle little jiggle you see from the heartbeat, it's gone too. When you have no sliding, no B-lines, and no lung pulse, man, you are getting really warm.
So, if the absence of sliding isn't enough to call it, what is? What's the clincher? Well, this brings us to the holy grail of pneumothorax ultrasound, the lung point. If you find this, it's game over. You've found your diagnosis. It is the literal smoking gun.
So what is the lung point? It's a dynamic sign. It's not static. It's the exact spot on the chest wall where the edge of the collapsed lung is just barely kissing the inside of the ribs with each breath. So on your screen, it's incredible. You'll see normal, healthy sliding lung, and then poof, it disappears, and you see the static line of the pneumothorax. Then it comes back. It's this transition point, the shimmering curtain appearing and disappearing. Once you see it for real, you will never, ever forget it.
So why does this matter so much clinically? Well, for one, it's pathognomonic. That means if you find a lung point, you have diagnosed a pneumothorax. Period. End of story. For two, where you find it can give you a rough idea of how big the pneumothorax is. The further you have to scan towards the patient's back to find it, the bigger the collapse. But, and here's the catch, if you have a massive, total lung collapse, the lung is just a little ball in the middle of the chest. It's not touching the chest wall anywhere. So you won't find a lung point. Just remember that. Not finding a lung point doesn't mean there isn't one.
Okay, so we've got all these individual signs. Let's pull it all together into a simple, step-by-step process. A structured approach is everything here. It's what keeps you from making mistakes when things are getting crazy.
Here's the algorithm. Step 1, find the pleural line. That's your landmark. Step 2, look for pleural sliding. Got it? Great. You can pretty much rule out a pneumo in that spot. No sliding? Okay, don't panic. Move to step 3. Look for B-lines. If you see B-lines, even without sliding, you still don't have a pneumothorax. But if both sliding and B-lines are absent, now you go hunting. Step 4, search for the lung point. If you find it, you've confirmed it. And of course, step 5 is the most important. Put it all together with your patient's story and your exam. And that quote just nails it, doesn't it? When you get comfortable with this stuff, understanding the subtleties of absent sliding all the way to the slam dunk diagnosis of a lung point, you've got this incredibly powerful tool. It lets you make fast, confident calls right there at the bedside that can totally change what you do next for that patient.
So I'll just leave you with this to think about. The next time you have that patient who's suddenly short of breath, or the one you just put a central line in, how is having this skill set, this framework, going to change things? How will it change what you do in those first critical minutes on your very next shift?